Okay.
Oh, okay, everybody.
All right.
All right. We got short talking points here today. Kelly is sick. And also, I might as well go ahead and make the announcement here. I'm going to be the new first contact person for the council. They rearranged the territories again, so I'll be doing the talks from now on. She may come in July. I don't know yet, but just so you guys are aware of that. Also, what the slide says, we're back out working again. So you guys, you need some help, you need some things, make sure you let us know. One particular thing, if we have any ISSP employers in our council and you need an activity credit, call me. I can take care of that for you because you're coming down to the deadline. So that's their ISSP. I think you have to have 3 activities. So if you need something done, let me know. Okay, next slide, please.
All right.
Okay, these are our virtual training courses. You're going to take these courses just like we're doing right now. And they got one on health hazard. That's June 22nd. The 28th is ergonomics basic principles. I'll be teaching that course again in December. The one that I wanted to tell you about, all right, August 17th is wellness in the workplace. That's a pretty good course, and yours truly will be teaching that with another consultant engineer from down in Cincinnati. So those are your virtual training courses. You can always count those, and they're very good. The scaffolding is particularly a good one too. Next one, please. Next slide, please. Okay, webinars. That's okay. I'm sorry.
Sorry, no, that's okay.
No, that's my fault. That's the hillbilly in me. Go back to one right there.
There.
Thank you, Michelle. You're the best. There's a webinar on safety training for new employees. And this one really kind of stuck out. Everybody's their brother's keeper. We have a tremendous amount of young people and people that have been on the job less than a year that get hurt. And a lot of that is lack of knowledge, and maybe, somebody could step in and help them. So one of the things, I just want to say, if you got new employees, and we have a lot of different types of new employees in our workplaces, don't be afraid to correct them. Don't be afraid to say something to keep them from getting hurt. If they're not doing something that's not right, you got to let them know. There's a employer update on June 30th that I highly recommend. And then that's the employer update webinar. Now that is through our employer services department. Now I know in safety accountants, we get a tremendous amount of business people that handle the business side of workers' compensation, paying the bills, claims, rates, the whole ball of wax. This is an up-to-date webinar. They use a PowerPoint, and they provide you really correct, good information on the business side of workers' comp, basically what you can do and what you can't do. I highly recommend this. I look at it, and you always learn something. So that is a good one to attend. And then on August 9th, there's a webinar on Better You, Better Ohio, Health and Wellness. That is something that our agency continually promotes, is health in the workplace. Okay. All right, next slide, please. And if you missed a webinar, this is how you can do it. You can go to the BWC Learning Management System, and you can type in replay, search catalog, and replay the webinar. So it's always out there for you. If you go back in it for reference too. Next, please. Okay. Anybody ever had to give a safety meeting? Probably about halfway into it, you start losing people. And a lot of academic people will tell you that most people can only keep a train of thought around 15 seconds. Okay. Some more, take me, for example, it's probably less, coming from West Virginia. So, but anyhow, I won't go there with that one. But these micro training safety series, what I call, they are quick hitters. They're a good toolbox meet. If you saw something that happened in your workplace during the day, maybe it was somebody used a container and the label was incorrect. Maybe somebody wasn't using steps correct. Well, there's a quick hitter that they can go to YouTube and you can show the video. The one on safety and the steps is 3 minutes long, but it packs all the information that that person really needs to know. It's a good safety meeting. Like I said, it's a quick hitter and it goes directly to the point. And those are all out on YouTube, and you can also get those through our website. They're very good. I wish they'd have had those when I was working in the trenches. Okay, next slide, please. Okay, this is how you can get those micro training. There's a bunch of them out there. HAZCOM, and another good one is the lock and tag. That's always a good one for industrial plants. That's good. Okay. All right. Today, before this meeting, I sat in on a training session that we had with the compliance specialist out of Columbia from OSHA. Excuse me. And one of the things that she talked about, well, the whole thing was on the national emphasis on heat. And one of the things that she was talking about, all the signs and symptoms. And one of the things that she said that really gets the compliance officers' attention, that if they get a complaint and they go on site, one of the first things that they're looking for is accessible, clean water. And if that is not on site, then they're going to be taking a look at everything. Not that you should be afraid of that. You should never be afraid of an OSHA inspection. You treat those people with respect and honesty, and you'll get it back. But on this heat thing, if you got people out working, if you got seasonal workers, if you're a landscaper, if you're working construction, you need to have that water available, and it has to be within a reasonable distance. And there's about 9, 10 other things that need to be done. One of them is to have a written program. I didn't know that. But with the climate supposedly changing, and you can see the heat out west, and it's starting here in the east, we have a lot of people working in that type of environment, and it is hazardous to their health if they're not acclimated to that. And that was one of the things that she pounded on. People need to be acclimated to the climate. So if you need more information on that, I'd be glad to forward that to you. But if you've got people out there working, make sure you have make sure you have water available for them, and a communication device that if there's trouble, they can get some help. Okay, that's the National OSHA Heat Emphasis Program. So you're going to be probably hearing more about that. Okay, Michelle, one more. You have the right to have a safe workplace. Y'all stay safe over there in Wooster. I love Wooster. It's a great place. The stores are safe. I worked undercover for COVID. Was in all the stores and was talking. It's a great town. Your stores are safe, but you watch out for people. And if it's on the job, you need to watch out for temporary and younger employees. With that, I'm done. Other than to say that I'm glad to be back in Wooster. And I will do the best job I can for you the 10 months, the 10, 11 months that I have left. I'm going to be spending with you. And I promise you, I will do the best job I can for you, because Wooster is full of good people. Thank you.
I think we do have a couple questions,
Sure.
I think, here. Farah had been trying to register for the June 23rd 7 Steps to a Successful Workers' Compensation Program. She's wondering how she gets into that. Is there something we can just send her, or?
Yeah, I need to get her phone number, call her, and work with her through that. So if you could get that phone number and forward to me, I'll call and we'll get that straightened out for you.
Okay,
I can do that. I can do right now on the computer to help, but I will get that straight for you.
Okay, that's fine. And then
typical guy, not going to help you.
Sean has a question, so I'm going to let him ask his question. Okay. As long as you unmute, Sean, you can go ahead and ask your question. No. Okay, if you just want to put something in the chat later, that is also fine. I think that is it. Thank you, Steve.
I have one more quick hitter. Next month, I'm going to do a rundown on all the grants that we have available for the good people of Wooster, safety grants, things like that. So that's what I'll talk about next month. Thank you very much, everybody.
Thank you. All right. I just wanted to give everybody a quick update on what we as a safety council have planned coming up. We are returning to in-person meetings in July. So July 27th, we will be in person again. We're really looking forward to seeing everybody. Rebates will be resuming with that. So everybody will be eligible for a 2% rebate on your workers' compensation premiums, as long as you're eligible for the rebate. We'll have the registration for that meeting up on our website shortly, and then we will go back to having fees associated with the meetings because we will be providing lunch for everyone again. We're also really looking forward to that. So Fire Chief Barry Saley with the Worcester Fire Division will be joining us in July to actually talk about heat stress and illness and ways to stay safe in the summer months. But today, we have Dr. James Nappi joining us to discuss common workplace injuries of the hand and upper extremity. So I will turn it over to you guys.
Okay, I'm Amy. I'm just going to get the sheet, share the screen for Dr. Nappi. Okay, there you go.
Good morning, boys and girls. If you have questions anywhere through this, don't hesitate to stop me or put them in chat, whatever you'd like to do. We can do them at any point. We're going to talk a little bit about some of the common workplace injuries that happen to the hand and the upper extremity. We'll break it down into two parts, trauma and some of the other repetitive motion issues that come about. And there's no question but that because of COVID, we saw a huge number of patients with very, very bad designed workstations working at home. And we've had a huge increase in the amount of tendonitis and nerve entrapments as a result of that. As we look at injuries, probably the most common injuries that happen in the workplace: laceration, crushes, amputations of one sort, puncture wounds, fractures, including slips, falls, things of that nature, and sprains and dislocations. A lot of this comes down to the age level of the workforce. It comes down to the body habitus of the workforce. And you will hear me put my plug in right now for the BWC ergonomic program. If there's been any level of repetitive injuries going on, we strongly recommend it. It can certainly mitigate a good number of these issues. We'll start first with the repetitive activity disorders, the tendonitis issues that are most common. Decurvains is a tendonitis about the wrist. Tennis elbow, relatively self-evident, and trigger finger. Of interest, they all tend to increase as we start getting past 40 years of age. Decurvains is just an inflammation along the radial styloid at the base of the thumb. Most commonly presents as pain with thumb motion. You have a positive Finkelstein's test, which we'll show in the next film area, where indeed you get pain in that zone, and any motion with the thumb causes a relatively excruciating type pain. Usual etiology is repetitive little finger side to thumb side motion with the wrist, especially with chronic repetitive lifting. The good news is Resting and splints along with nonsteroidals for a course of about 3 to 4 weeks will usually resolve about 50% of these. If quicker return to activity or they're refractory to conservative management, steroid injection will at least temporarily cure 98 to 99% of these. If they become recurrent, however, the hallmark of treatment is going to be behavioral modification, changing the ergonomics. Surgery for deeper veins tendonitis, very infrequently necessary, probably in the 2 or 3% range. Tennis elbow, 1 to 3% of the general population will indeed show up with this. In manual labors, it's about 7 to 8%. The peak age or incidence of this will be 40 to 50, 55-ish. The good news is that 80 to 90% of patients with this will resolve within a year's time, regardless of the form of treatment. Multiplicity of things have been done for this. Of interest, the Australians recently published a study where they actually put half their patients into a sham surgery group. They made an incision and closed it versus patients who had tennis elbow surgery. Their outcomes were identical in both groups. The hallmark of treatment for lateral epicondylitis or tennis elbow is going to be behavioral modification. That coupled with a good program of therapy. My own personal experience in the last year or two is I have seen better results from kinesiotaping with a therapist than much of any other form of treatment. Injections can be considered, corticosteroids, PRP, of interest. If you just stick them with a needle called dry needling in that site, the outcomes are all about the same. So this is something that a repetitive activity disorder, surgery is almost never going to be indicated. Trigger finger, that's nothing more than a pain, locking, or clicking of a finger into a flex position. It is a repetitive grip or sustained grip etiology, extremely frequent in the over 50 population. Usually the finger locks and it's extremely painful during the unlocking process. Generally, a night splint along with a nonsteroidal for about 6 to 8 weeks will get 50% of these better. Should that fail, or again, we're trying to get back to activity quicker, injection is about a 98% resolution rate within about 2 weeks' time. Surgery is appropriate should conservative treatment fail. However, these patients will be profoundly impacted in sustained grip for probably a good 6 to 8 weeks after surgical intervention. Compression neuropathies is repetitive motion, carpal tunnel syndrome, cubital tunnel syndrome, radial tunnel syndrome, miscellaneous such as thoracic outlet compression, which has had a significant rise with the bad ergonomically designed home workstation. Carpal tunnel syndrome, 3 to 6% of the general population will have this. The incidence most definitely increases with age. Anytime you start getting beyond the age of 40 and start maturing further, the incidence will significantly increase. It is predominantly numbness and tingling in the fingers and thumb, occasionally interpreted as pain. It is nothing more than the description of an anatomic location, the carpal tunnel at the wrist, where you have a zone of a tunnel that contains the tendons that bend the fingers and thumb down, the median nerve, and a bunch of tendon lining. Repetitive activity or sustained grip will cause a swelling in that zone, which puts pressure on the nerve and brings about the entity. Forms of treatment, One can start as simply as a night splint if most of the symptoms are nocturnal. Injection can be both diagnostic and therapeutic. Behavioral modification can be beneficial. Surgery, should conservative treatment, certainly can be entertained. It can be done openly. It can be done endoscopically. Huge debate. Those of us that do endoscopic release do feel there is about a 7 to 10 day fewer off work time. That's been well documented in several papers, although there's a lot of debate about that still. Return to work varies profoundly for anyone with carpal tunnel. It has to do with the level of activity one is doing. If one is doing a light clerical type activity, a week or two of downtime is usually sufficient to be at least significantly functional. The most profound adverse outcome after carpal tunnel surgery is a 50% reduction in power of grip that takes on average 10 to 12 weeks to recover. If you are doing a heavy manual labor activity, carpal tunnel surgery is going to keep you from doing that same level of activity for probably a good 10 to 12 weeks. If you can modify somehow the work activity, return to work is much quicker. But this is all very, very subjective. Most profoundly, John Agee, one of the inventors of an endoscopic technique, in his original description found that his non-workers' comp individuals on average were back at relatively full duty by about 4 weeks' time. His workers' comp individuals averaged about 10 to 11 weeks' time. This is a very, very significant change, and a lot of it has to do with one's ability to adapting the activity. Most profoundly, as we get into failed carpal tunnel surgery, the correct diagnosis profoundly matters. EMGs are false positive or false negative 3 to 15% of the time based on what the study you're looking at. MRI reports are an impression of somebody looking at shadows who's never examined a patient. These are not diagnoses. They are test outcomes. Testing may help support a diagnosis, but in and of itself does not make the diagnosis. In our experience, the most common reason to see a failed carpal tunnel surgery is that the wrong diagnosis, an EMG most likely, was used to justify doing surgery. The patient's complaints, the patient's exam would be totally compatible with something other than that. Cubital tunnel syndrome, that is the ulnar nerve at the elbow level on the inside. That's feeling in the other two fingers. Weakness of the hand intrinsics, a lot of clumsiness. Elbow pain frequently can be associated. It's broken down into two types. Most commonly, we'll see cubital tunnel from chronic, repetitive, loaded flexion extension of the elbow, lifting, or sustained elbow flexion. The other is the bad home workstation direct pressure on the inside of the elbow for prolonged periods of time. They're treated totally differently. Generally, an elbow extension splint will resolve about 80 to 90% of classic cubital tunnels from repetitive flexion extension. The elbow splint is usually inadequate. What one needs is actually an elbow pad or an elbow sleeve to pad, and attempts at behavioral modification to treat the direct pressure form. Should one be unable to exert good long-term results for conservative management, surgery can be considered. Surgical interventions, again, come down to which type of cubital tunnel we're dealing with. The repetitive activity flexion extension can be very easily treated with a simple cubital tunnel release. The patient with direct pressure usually does not get better with that surgery, and that is someone who almost always will need a transposition of that nerve to get it out of the zone of compression. Radial tunnel syndrome, irritation of the third major nerve in the upper extremity through the supinator muscle. It happens about an inch below the point of a lateral epicondylitis or tennis elbow. They frequently can be confused. Electrodiagnostic testing for radial tunnel is almost always normal. It is a clinical diagnosis made by examination of the patient. Ultrasound exams, MRIs are fraught with false impressions. It is predominantly pain in the muscular area over the course of the radial nerve rather than indeed pinpoint tenderness of tennis elbow. Treatment generally is rest, modified behavior, avoiding a chronic or repetitive palm up, palm down activity, which stimulates the supinator to compress the nerve. Behavioral modification, along with therapy, will resolve well over 95% of these patients. However, it is usually a 2 or 3 month adventure. Again, there's been a lot of good early indications that kinesiotaping for behavioral modification may be beneficial. Ergonomics, this is a second plug for the BWC ergonomic program. I strongly, strongly recommend it. Okay, now we go to the trauma, the lacerations. What gets cut? Can be skin, muscle, tendons, ligaments, nerves, arteries. Based on what is injured in the hand or upper extremity, we talk about forms of treatment of this. If we look at a hand that's been skinned on the palm side, there's a whole lot of stuff in there. Arterial supply, that's the red lines, the white little tubes of the nerves. We have tendons down the middle of the digits that will indeed cause things to bend or straighten. We have muscles that control position. All of those can be injured. Tendon lacerations, this is a BWC nightmare. This is a prolonged issue. This individual is a sous chef who, while chopping veggies, slipped on the knife, and the 2 white lines on the ring and the little finger are his points of laceration, and he's unable to bend because he's cut the tendons. Tendons can indeed be repaired. The problem is that a repaired tendon is about 10% as strong as a normal tendon. Does not gain significant tension and strength for almost 6 weeks' time of healing. If these patients are treated with immobilization, the tendons will lock down to all the other tissues and scar in place, kind of like rebar setting up inside of concrete. If one moves too early with load, one basically will tend to rupture and be right back to where you started. So it takes a very, very complicated and very extended therapy program. Normal ability at gripping is generally going to be 8 to 12 weeks time. This sous chef was actually back in some level of activity at about 1.5 weeks, but was not doing his full duty level of activity until he was 10 weeks post tendon repair. There he is showing you at least at 3 months time that he's now able to bend those fingers. But again, a very, very prolonged, protracted workers' comp issue. Nerve injuries, artery injuries. Nerve injuries cause diminished sensation or loss of dexterity, or based on the level, diminished control of muscles. One becomes susceptible to re-injury, and one also has the potential of being unable to discriminate or have fine level dexterity. Arterial injuries primarily are a hemorrhage issue acutely, but if after the hemorrhage has been stopped, they can lead towards delayed healing, delayed nerve recovery, and long-term cold intolerance, especially in Ohio come wintertime. Someone who is an indoor worker is going to be much less prone to cold intolerance. Someone who is an outside worker or someone who works in a cold environment year round will have a much bigger issue with a long-term cold intolerance. Outcomes, all of these outcomes will be very much dependent upon how treatment is basically approached. Not all nerve injuries need repair because repaired nerves never return to normalcy. The results very much depend upon the level of trauma, the extent of the trauma, and the age and the motivation of the individual. The younger the individual, the closer to normal sensibility recovery and motor recovery becomes. The older the individual, the less ideal the outcome. Under the age of 20, sensibility recoveries are close to normal, but not quite normal. Between about 20 and 40, there are very good functional level recovery for activity. Between 40 and 60, sensibility is relatively mediocre. Recovery when one gets beyond the age of 60 is relatively poor and at best may be protective and may not even become that good. Nerves that are injured recover at a rate of 1 inch a month from the point of injury. If one takes out their median nerve, the carpal tunnel nerve at the wrist level, recovery of feeling to the end of the middle finger is going to be about 6 to 8 inches or 6 to 8 months. It will then require about the same amount of time for sensory re-education. So the overall level of this, a lot comes down to how bad is the injury. Personally, as a hand surgeon, I'm only missing 4 different digital nerves on my left hand from 4 separate injuries. I've had none of them repaired, but I do happen to have 4 areas of diminished sensibility. However, it doesn't significantly impact my ability at function. It's a choice I made. Cut nerve does not necessarily mean have to have surgery. Here, if we start on the right, the big white globs, and this is exploring a thumb at about the second crease level or the base of the thumb, where a knife went across and took out the nerves. Those nerve endings or neuromas are trimmed back. And if we look at the opposite side, we now have 2 little cables that have been repaired with some sutures about the diameter of a hair. Young individual here, about 25, expect a reasonably good level of recovery in a thumb. Thumb nerve intervention, much more important than intervention on one nerve in one finger. All of these decisions take a lot of input in questioning the individual and what their motivation level is. Arterial injuries, before we get to puncture wounds, again, the primary goal there is repair if necessary to prevent the cold intolerance issues and to help at nerve recovery. Puncture wounds, this can be anything from a fish hook to a sawzall blade, which is what this case is. Most significant thing to notice with this puncture wound is assessment of all of the deep structures in the course of the path of injury. In this case, the obliquity of this blade when it flew off the sawzall managed to miss all the major nerves and tendons. Sawzall blade was simply extracted. The biggest error in treatment with this is that frequently somebody will very tightly lace up that little laceration, and you have a huge dead space that has indeed introduced a bunch of dead skin, dirt, grime, and a high level of abscess and infection afterwards. Appropriate treatments, adequate debridement of that wound, and then leaving the wound open to heal by secondary intent. It takes a little bit longer to get to healing, but significantly reduces the likelihood of infection. Amputations, avulsions, these can be fingertip injuries, whole fingers, whole thumbs, hand, forearm, upper arm, the mechanism of trauma, the amount of injury, patient's commitment to rehab. All of these are going to be factors in making decisions of what is the right way to approach this. We start out with something fairly simple, like a little fingertip avulsion. By the way, if these photos now get bad, the barf bags are under your seats. Treatment options for that wound. You could use an open wound technique, just keeping the wound covered and letting it heal by secondary intent. That would advance normal sensibility skin. You could shorten the bone and put sutures in. However, by shortening bone, you'll lose stability for the fingernail and increase the likelihood of nail deformity. One could talk about skin grafts. They will get you a healed wound quickly. However, they won't develop durability and sensation. One could talk about flaps, advancement from the finger or from distant areas. All of those are considerations. For functional outcome of this type of injury, the best functional outcome actually comes from an open wound technique. The problem is you're dealing on average with about 6 weeks of an open wound to healing time. However, the ability obtaining a functional long-term finger is quite good. Generally with this, we would apply a little Vaseline, occasionally some Neosporin if there's concern of bacterial load, and a Coban wrap or some facsimile thereof. This fingertip's actually an old friend of mine from Florida who's a now retired hand surgeon who did this in a door he was making in his wood shop and decided that tip was definitely way too crushed to even be tacked back on as a biologic dressing. So he used cross Band-Aids and was nice enough to do serial photos. As you look at it about a week's time, on the left-hand side, you will see a lot of granulation tissue beginning to form. That's the healing area and the beginning of wound contracture. By 3 weeks after that injury, you can see that the skin is beginning to profoundly advance and contract in. Here he is at 40 days. That's finally healed a wound, just short of about 6 weeks' time. But he's still dealing with a lot of chronic crusting and callus that basically takes a lot of massage, a lot of scar modulation activities, and desensitization. He will then basically settle that down over the next 2 to 4 weeks' time. And he was nice enough to give us a 2-year follow-up on that same finger. And I think if you look on the right, you can appreciate it's a little bit flatter. It's not quite as rounded and long, but the tip has reformed extremely well by cross Band-Aids. There is a difference as we look at the center of that fingertip on the right of the fingerprint. It does shift and alter some of that. However, extremely functional, extremely durable. He was back in the office 2 days after his injury because he got hurt on a Saturday and didn't normally go to the office on Sunday. So rather quick return. These patients need to be assured that indeed these wounds, less is actually more when you look at the long-term follow-up. And a lot of surgeons have a problem accepting the fact that less can be more when you look at functional outcomes. This is what happens when we run out of sawhorses. And this is what happens when we put our hand back there to try to blunt that blade. That may be a candidate to consider reattachment. Or this is what happens when a corn picker grabs the arm of a 54-year-old gentleman and rips the arm off. And that is just crushed and avulsed. In this case, that is not a candidate for reattachment. In this case, what we did is looked at trying to salvage a big, huge area of tissue off of that amputated part and wrapping it around the stump to try to salvage the elbow. As we look at somebody who's doomed to poor outcome with replantation and is better in prosthetics. The critical aspect of prosthetics is salvaging the elbow. Prosthetic use in a below elbow amputee runs now between about 90 and 95%. Above elbow amputees are probably at best about a 10, maybe 15% reliability of prosthetic wear. So we look at this as at all cost, attempt to salvage an elbow. Here's a thumb ripped off in a punch press. We could try secondary intent. However, that's going to take a long time to heal because you've got bone sticking out and you're going to basically contract with no functional thumb. Thumb is about 50 to 55% of our hand function because unlike all other primates, our thumbs come out of our palms so that we can grasp. Here, a lot of discussion had with the patient of options, including a flap as a reconstruction. This was a relatively young individual at 30. So what we did was actually took the end bone of his big toe with an area of skin, wrapped it around that bony stump to give him something that looks like this a day or two after the initial injury. Goes home with a sore toe as well as a sore hand, but gives you at least the recovery of a sensate, cosmetically acceptable looking thumb. There it is as we start looking 6 to 12 months down the road. And I'm a bit self-critical. I think they always look like toes. I don't think they ever really look like thumbs. You can do a second toe and it always looks like a little finger. You can do a big toe and it always looks like a dang big toe. Sculpting, you can try to change them some, but they always look a little abnormal. But in this case, thumb is a functional digit restored in a fairly simple, semi-emergent fashion. Or another punch press. Here, the whole palmar skin of the thumb has been ripped off, but the bones, the tendons, the nail all remain. In this case, we merely took a flap off the toe the following day, put a little skin graft on the toe so the toe has been maintained, and resurfaced the area of that wound with one nerve inside that skin flap to get a reasonably functional thumb that recovers relative motion and permits return to a mid-20s individual on a punch press. Had this individual been in his 50s, other options may have been considered because of the level of sensibility recovery. However, the callousable skin on a toe on the palmar aspect of a thumb is a much more durable functional skin than one gets from other locations. Okay, now we go to fractures, dislocations. Another one of the chronic nightmares that exists, especially in the workforce. The most common adverse outcome of fractures and dislocations is long-term stiffness. All fractures and dislocations have significant soft tissue injuries. All soft tissue injuries heal by making a 4-letter word called scar. Scar in the first 4 weeks or so is soft and gelatinous and then sets up like concrete and gets stiff. Prolonged splinting of dislocations and fractures leads to prolonged and frequently irreversible stiffness. Early mobilization profoundly reduces stiffness post-injury. The finger extensor mechanism on the top aspect of the finger is extremely prone to scarring down to fractures. So rapid mobilization is utilized in order to try to prevent that. Here, a couple of classic dislocations. To the left, a simple direct blow with full extension injury where the middle joint pops out of place. That needs to be appropriately reduced, looked at from an x-ray standpoint, and then splinted for a day or two for comfort, but moved as soon as possible. And most patients feel like, oh my gosh, they told me I was going to have to splint for forever. The longer you splint, the stiffer you get. The right side shows a fracture dislocation. That's a dislocation that had a rotary component where a chip of bone came off the bottom aspect. There, appropriate reduction is obtained, and that can be early mobilized. Seldom will need surgical intervention. Dislocations, the basic premise: reduce the joint and restore the anatomy, and then begin early mobilization. You may need to consider some protective extension block splintings, but attempting full flexion is extremely, extremely encouraged. The joint from about 10 to 20 degrees of flexion is completely stable and cannot redislocate. So beginning these patients with a buddy tape program generally will protect them enough that they won't redislocate and they can be mobilized. Extremely critical in the long-term outcomes. Again, the most significant aspect is that dislocations or sprains are going to all heal with scar. I believe the Miller criteria says sprains are done at 6 weeks. If we look at scar, which heals these, scars is maximum production and most tender and most stiff at 6 weeks, and requires another 6 months to soften and become non-tender and non-swollen. So a standard recovery from a dislocation is going to be at least a 6-month adventure, not 6 weeks. Fractures, broken finger bone on the left, a broken forearm and wrist bone on the right. Both of those are somewhat displaced. Both of those need some level of intervention. We classify fractures as displaced or non-displaced, stable or unstable. Stable meaning that it sits in that position and relatively holds that position. Unstable means the tendon, ligament, or fracture pattern wants to fall apart and bring things into becoming crooked. That becomes very, very critical as we decide if they need intervention or not. They can be described as open or closed, meaning whether or not part of the bone is sticking out of the skin. That has applicability only from the standpoint of potential infection. Clinical malrotation is probably one of the most significant things we assess. All fractures that are stable can be treated with an early motion and protection program. All fractures that are unstable need to be made stable with some form of intervention, as simplistically as possible pinning, or as complicated as screws, plates, some other form of treatment. But the goal is make the fracture stable and then move it. The longer we spend splinted, the more scar we get. The more scar we get, the stiffer we get. Controlled motion, as simplistically as buddy taping, is quite acceptable for a profound number of these injuries. Here, punch press crushed to a hand with multiple fractures of the metacarpals, taken initially to the operating room, where all of the fractures were stabilized with multiple pins, and the patient started in therapy in 2 days' time, geared towards working on the swelling and geared towards range of motion. The longer we wait in a splint, the stiffer we're going to get and the less optimal the outcome. Unstable fractures are made stable so that you can start early mobilization. Today's question: is that a fracture or is that a sprain? If you read the X-ray report, it says, oh, that's a volar plate avulsion fracture. Oh, so that gets splinted. And if that's splinted for about 3 weeks' time, that finger will bend on average about 10 degrees at that joint because of scar. A majority of that injury is soft tissue and ligamentous. That is a variation of a dislocation. That little bone chip needs no intervention. That joint needs early mobilization to maximize the outcome. Again, if we're looking at something as simplistic as saying, oh, it's a broken finger, we think we can't move it. Here, Motion is the most critical early thing for that. Fractures, dislocations, the secret to this is therapy, therapy, and therapy. And when you're done with that, a little bit more therapy. Okay, do we have questions out of this group? Anybody want to throw vegetables at me?
I don't see any questions coming through in the chat. Anybody does have any questions, please put them in the chat.
And I'll get my last plug in for the BWC ergonomic eval. It has all the difference in the world in outcomes of dealing with this stuff.
Steve, did you have a question? Yes,
Yeah.
now I can.
Yeah, I have a question. I have a few comments for the doctor. That was excellent. That's one of the best explanations I've ever heard for the different type of trauma, that goes to the body. I'm an ergonomist, and one of the things that I find, I don't know if I got my screen on now or not, but one of the things that I find when I go into a workplace, I talk to a lot of people that have, and I'm going to talk specifically about carpal tunnel because everybody's spending a lot of time on computers now, and so we're more susceptible to some of these disorders. But I have talked to a lot of employees where I got called in to look at a situation in a workplace, and I talk to the employee, and they'll tell me, "Well, I had carpal tunnel surgery, on both hands, and this workstation still makes me hurt." And so one of the things that, and you may have said it and I may have missed it, but one of the things that we really hammer Ohio employers on is that if they got an employee that went in, let's say for carpal tunnel or epicondylitis or some type of disorder from sitting at a workstation, one of the things that we want to happen is for the workstation to be, for those deficiencies to be corrected before that employee gets put back into that type of environment, because we find that they just start to hurt worse. So, I mean, I just think it's important that the employers, I think we do a good job in the state of identifying the hazard and then getting the people treated, but sometimes we don't treat the root cause, I guess what I'm trying to say. And I think that's very important to me as a tactician when I go in and try to help somebody that they're working at a workstation that, came out of the 60s and 70s. So, and that's all I had to say about that.
Oh, I happen to be very much in agreement with you. It is a hallmark of getting these people and maintaining them in the workforce is the ability of adapting the activity. And most common, one of the big issues that happens with BWC is once you have been labeled with a diagnosis, you carry that for forever.
Yeah.
Oh, you had carpal tunnel surgery to take pressure off your median nerve. Okay. And if you got resolution because it was done for the right reason, you no longer have carpal tunnel surgery or syndrome. If we are back on the line and we're hurting, my question is, pain is not that common with carpal tunnel, numbness is. What is the correct diagnosis? Oh, unfortunately, BWC says it's carpal tunnel syndrome, even though it has been priorly resolved. Is it now recurrent carpal tunnel syndrome? That would be profound recurrence of the numbness and tingling, not necessarily pain. Are we dealing with a tendonitis pattern? Are we dealing with, we also had an underlying early arthritis? I have a series of 6 patients who had multiple carpal tunnel surgeries done, all out of one industry, because of
positive electrodiagnostic testings. If you ask them what their issue was, all of them had pain at the base of their thumbs. They didn't have numbness and tingling. Guess what? After carpal tunnel surgery, they didn't have numbness and tingling either. Carpal tunnel surgery was done because of a positive EMG. All 6 of those individuals had different levels of early arthritis of the basal joint of their thumbs. They were all around the age of 50 in heavy manual activities, and they had surgery for a diagnostic test. Somebody didn't do an exam and figure out what was really going on with them. So a lot of this has to do with making a right diagnosis and then finding a way to adapt the activity. Sustained gripping is notorious for aggravating carpal tunnel type symptoms, because during sustained grip on a small structure, one migrates the lumbrical muscles that control finger motion into the carpal tunnel during grip. Sustaining that increases pressure profoundly, can bring about significant recurrent symptoms. We find it in motocross riders as well. I found it working with a chainsaw, and my adaptation was a padded buildup so that I'm now grabbing something that's 2.5 inches in diameter and soft and padded, and I can go for an hour on a chainsaw without symptoms, whereas I got bad ones at 5 minutes before. So all of those things are the things we look at. It's learning adaptation. I think that is really the secret to continuing people in the workforce. You can throw more veggies if you want after that response.
Thank you very much. Thank you very much.
Yeah. Awesome. Yeah. Thank you very much. I don't see any other questions in our chat. So if nobody else has anything, thank you so much, Dr. Nappi, for presenting. I thought this was really informative as well.
My pleasure. If you do have questions later, don't hesitate to contact Amy. She can get things to you as we need to.
Awesome. All right, we will do that. Thank you. You too.